I am Deborah Kay. Welcome to PsyTech's webinar on psychedelic-assisted psychotherapy for eating disorders. We are very fortunate today to have as our moderator, Dr. Michael Levine. Dr. Levine is an emeritus professor of psychology at Kenyon College in Ohio, with a special interest in prevention, socio-cultural risk factors, public and professional education, and advocacy. He is also co-author with Dr. Linda Smolak of the forthcoming Prevention of Eating Disorders and Eating Problems. Thank you so much, Dr. Levine. I'll hand this over to you now.
It's my pleasure to be the moderator for this distinguished panel and to be involved in what is literally a cutting-edge approach to the treatment of eating disorders. What I'm going to do is to allow each of the panelists to introduce themselves briefly and to give you a sense of their connection to this topic. And then I will start with a question for Dr. LaFrance, and we will go on from there in a more unstructured fashion, but hopefully addressing a lot of topics that people want to see. So let's start with Dr. Robeson. Reed, go ahead.
Hi there, thanks, Michael. My name is Reed Robison. I'm a psychiatrist based in Utah in the US. And I have been working with ketamine for about 9 years, doing research and clinical work. And I specialize in eating disorders as medical director of a treatment center out here in Utah called Center for Change. And more recently have been working with Adele on an MDMA study for eating disorders through MAPS, and doing some research with ayahuasca as well. Excited to be here.
Adele?
Hi, I'm Adele LaFrance, and I'm a psychologist and adjunct professor from Canada, but now working in the United States. I've been working in eating disorders for the length of my career, co-developed a treatment model, emotion-focused family therapy, and now turning my attention to the potential for psychedelics in the context of eating disorder treatment and recovery. I'm part of a number of research projects at this time with MAPS, with Imperial College, with Psychedelic Institute, and I'm really, really excited to be here to be with my colleagues here to talk about this really important topic.
Janet?
Hi, I'm Janet Treasure. I'm from the South London and Maudsley Hospital and King's College London. I'm a psychiatrist. I'm really here because I'm the mentor of Carol Cann, who's the real expert in this area. But because of mentoring her, I've had to broadly increase my area of expertise into this domain. But on the other hand, I've also been very closely connected to Adele because we both share this common interest in involving supporters of people with eating disorders, and are passionately interested in that as well. So we're multifacetedly interested, I would say.
Carol?
Hi, I'm Carol. I work at the Maudsley in London. And I work with Janet Treasure. I'm interested in depression and the overlap with eating disorder, especially anorexia. And I've been working in ketamine clinic at the Maudsley, treating people with treatment-resistant depression using ketamine.
Thank you. I'm going to start with a question for Adele. Adele, I think most of our listeners know that eating disorders are very serious, all too often chronic mental illnesses that revolve around, at minimum, significant issues with anxiety and with control and with a sense of self that's all too easily fragmented or lost. Why would any reasonable person, let alone distinguished, highly educated people like our panelists, think that psychedelic drugs would be valuable for helping at least some people within this vulnerable population?
Thanks, Michael. And I'll be totally honest, I had the very same questions, and I would say fears, actually, related to psychedelic medicine when I started learning about the potential of these substances to support mental health and wellness. And it took me some time actually to learn about it from mentors who I trusted. In fact, I remember early on sending Janet an email basically asking, like, is it okay for us to be looking at this? And of course, she was so encouraging, and we're reminded by the fact that these illnesses are really difficult to treat and people suffer greatly. And so when I started learning about the potential of it, I felt like it was really important to at least check it out. And so did a lot of thinking and talking and interviewing, including people with lived experience, and was really encouraged. Now, I think it's important for us to kind of clarify for people watching today that we're talking about the potential for psychedelic-assisted psychotherapy. So this is in the context of legal use, carefully controlled research studies, hopefully eventually healthcare, where attention is paid not only to the potential of the substances, but to screening, to preparation, to integration of these experiences so that it can promote health and healing. So that's really what we are talking about today, where our interest lies. And I want to mention the work and the research of our colleagues at MAPS, at Imperial College, at Johns Hopkins, because in their preliminary investigations of the use of these substances with different clinical presentations, like they've really paved the way to demonstrate, like, done carefully, done respectfully, we can help people who are really suffering in ways that perhaps conventional medicine can't on its own. And so I think it's exciting for us to be able to kind of take what we've learned from our colleagues and our preliminary investigations to think about, like, how do we make this work given the very unique features of eating disorders, not just as an illness, as a disorder, but also in terms of how it affects all the members of the family. And so we're not just looking at psychedelic medicine for the individual, but also thinking about, okay, how can we use what I think the field of eating disorders does really well, leveraging the power of caregivers to support healing, also being guided by the amazing work that our colleagues are doing already in the field of eating disorders. And so in terms of like specifics for how psychedelics could work, I'll pass it on to Reid, who I think does a really beautiful job of talking about how it can be helpful in specific ways.
Thanks, Adele. I'll give two ways that stand out to me as ways in which psychedelics can help with eating disorders. The first about how they help the brain, and the second about how they help with the therapy process. And so first of all, psychedelics interrupt what is called the default mode network, this collection of pathways in the brain that govern how we function in day-to-day life, our thought patterns, our stories about ourselves and the world. So you could think of the default mode network as the location of the ego in the brain, and psychedelics turn this down. There's an analogy I like to use, especially living in Utah where we're proud of our skiing out here. You could think of the mind like a ski slope, and all of your thoughts and actions traveling down it. Ruts and grooves are made in the snow. As people ski down the hill, they get deeper and deeper over time. Pretty soon, no matter where you start or even aim, you're likely to slip into the same ruts and end up at the same location over and over. And like a ski slope, our minds develop these kinds of patterns as we navigate the world. And with psychedelic medicines, it's like a fresh coat of powder over this ski slope, providing a blank slate, a break from these ruts, these everyday patterns. And this lets you choose the next set of tracks and end up consciously arriving at new destinations. Why this is important in eating disorders is there can be a lot of rules, a lot of deeply ingrained patterns about food and the body and how we show up in the world. And so the second thing I'll point out is how psychedelics help accelerate the therapy process. These are emerging as powerful catalysts or tools to accelerate the healing and recovery process, including in individuals with eating disorders. And let's talk about MDMA as an example. Because of, well, it's such a unique medicine. Adele and I are working on a study with MAPS for MDMA-assisted psychotherapy for eating disorders. And MDMA is known to increase acceptance of self and others, increased tolerance of emotionally upsetting topics, the ability to go deep and address these things without disorientation, dissociation, and overall increased self-compassion and trust of oneself and the therapy team and family members. So I think I'll stop there as two ways that I'm excited about psychedelics and eating disorders.
Reid, could you elaborate just a bit more? In my far from limited experience with psychedelics, most people, when you say that word, are thinking LSD, possibly psilocybin. It seems like you and Adele are using the group or the category in a much broader term. Can you say a bit more about how broad your conception of what a psychedelic drug is?
Sure. And the term itself is, I think, a fun one. The word psychedelic comes from the Greek term to wander in the mind. And so I see it as a way of shedding light to the dark corners of ourselves and bringing awareness to patterns and ways of thinking and behaving that we don't always have awareness of. And there are classic psychedelics like mescaline, ayahuasca, psilocybin, LSD. And then the definition has broadened in recent years to include, in our opinion, MDMA, ketamine, and even others. So does anyone else on the panel have anything to add to that?
Well, sometimes things like ketamine are put in a subcategory of dissociated types of them. So I think perhaps we can categorize them all quite differently, so they aren't, it's been used quite broadly, but we do understand quite a lot about how they act in the brain now, and they do act on different pathways. So I think the amount we know is so much more advanced than it was when these substances were first used and actively investigated 40 years ago.
Yeah, I think it's true, because there was one study that was done quite a while back in people with anorexia using ketamine that Janet showed me to. It's about 20 years ago they did it. So, but the dosage is so different to the dosage we do it now. People were have it for an infusion for many hours. So the research has moved so much ahead now compared to what we know. But there's been a real lack of research in eating disorder using psychedelics. I mean, we found one study, and I found one case study that they did in psilocybin in France and anorexic. And that's all that we can find. So the field is really lacking behind in that sense. And also we know that people with eating disorder have a lot of comorbidity, like depression, anxiety, and those drugs has special, like ketamine, it's been shown to work, be helpful in people with treatment-resistant depression. Not in everyone, but in some patients. And it does make sense for us to try to try in people with eating disorder.
I think what we know is that there was a great expansion of work in these areas 40 years ago, and for political reasons, the war on drugs, this was all stopped because it was impossible to get these drugs and to continue with treatment experiments. In Eastern Europe, Russia, studies were done, so there is more of an evidence base there. So it's only now that people are starting to do randomized trials, and rather nice ones, including psychotherapy, but it's hard work, because overcoming these barriers of legality and the costs involved in that and the effort to convince ethics committees is quite phenomenal. But as Carol says, we know so much more about the biology of all all psychiatric disorders than we did 40 years ago. And what we know genetically is there's a lot of overlaps between anorexia and depression, obsessive compulsive disorder, schizophrenia. There are some differences, some metabolic aspects of susceptibility for eating disorders, but it's not surprising that, you know, we have to look out of our silo of eating disorder to what's going on in depression, what's going on with severe anxiety, post-traumatic stress, alcoholism. And here we see many studies coming out showing good results. So we know our patients really do so often have a severe enduring illness. So we've got to think of other ways. At the moment, deep brain stimulation is being used. We need to think of ways that are less intrusive as that. But Carol can perhaps tell us a bit more, because she's been seeing what people with lived experience think about this. Carol.
Before I turn to Carol, come back to Carol, Janet.
Yeah.
Could perhaps you or Adele give us a bit of background about some of the perhaps successes that are already present in the treatment of eating disorders, and also some of the limits so far? In other words, if psychotherapy or cognitive behavior therapy, for instance, were 100% successful in helping people with anorexia nervosa or bulimia nervosa, we wouldn't be talking about the need for different forms of assistance with psychotherapy. Mm-hmm. So as therapists, perhaps both of you could talk about, or Reid too, talk about, again, this is part of why people are turning to what seems to some people like an extreme measure. Mm-hmm. Adele has told us that it's not as extreme as what we're talking about given the context, but there have got to be some challenges and frustrations for all of you who are therapists in working with these patients that leads you to want to expand your minds and expand your practices with regard to psychedelic-assisted therapy.
Mm-hmm. Thanks, Michael. And how I started my investigations of this potential is that I was working in an eating disorder program, and in a very short time span, we lost 2 of our patients to the illness, and it really, it hits us all very hard. And at that time, I watched a documentary on the nature of things, which is a science-based documentary in Canada, and I heard Dr. Gabor Mate talking about ayahuasca in the context of addiction. And I watched the documentary. I'd never heard that word before. I really knew nothing about psychedelics, but having these women in my mind and in my heart, watching this documentary, I thought, I need to learn more about this. And so I emailed him more than once to ask him, like, tell me more. And that's when I started interviewing individuals who had experiences with eating disorder, including with conventional treatment programs, and who'd sought out ayahuasca experiences, to ask them what it was like, how it helped them, and also what the risks were, what the issues were. And we came out with a pretty balanced view that it helped some people, not everyone. Some people it helped a lot. Other people encountered risks that were serious and needed consideration. Particularly, one in particular I'll note was that one of the people I interviewed was sexually assaulted at a retreat center for ayahuasca. And so I was so happy to kind of get that lay of the land from that particular study, because it alerted me to not just the potential, but also the fact that we need to be very careful and very conscious about how we explore the potential of these medicines in a good way, so that we can optimize outcomes and then minimize risks, and also avoid completely some of those adverse events that could happen. So that's how it kind of got started for me. And so I'm really, even the study that we're doing, Reid and I, with MAPS and others, it's a safety and feasibility trial. Like, we want to learn about the markers, we want to learn about the risks, we want to learn about the safety, and also the potential outcomes.
Well, thank you. Janet, could you say a word about psychotherapy and outcomes in the eating disorders, again, that set the stage for why we're talking about this?
Well, I think
What's the general outlook in terms of if I had a son or daughter, God forbid, that had an eating disorder, and I came to you and said, what are his or her chances of recovery with, even with a distinguished expert like you, what would you say?
I would want to know how long they've had the illness, because that is a very important marker of prognosis. And so if it's early on in the course, you can expect sort of 40% perhaps recovery within the first few years. However, once it's gone on for over that time, then the chances of recovery are much later. And in adult populations, at 10 years, 60% are still poorly, very socially isolated. 20 years, there is more recovery, but it's only 30%. So people have a long time of disability. And as Adele pointed out, the mortality is substantial. And similarly, I mean, I think perhaps some of us are focused, I am guilty of this, of anorexia nervosa, but bulimia nervosa and binge eating disorder also have these rather chronic courses. Not as much, so 60% have recovered by 10 years, so it's less of a problem, but psychotherapies only do so much.
All right. And Carol, tell us about some of your, I know you've done a lot of different types of research, but you spoke with us earlier off camera about survey research that you did. Maybe you can start talking about some of that survey research and we can branch out from there.
Yeah, so it's interesting because one of the questions they asked was in one of the Q&A is that what I've learned from doing this work that I changed my belief. So I did a survey in the UK, it's still ongoing, asking people with eating disorder their view of alternative treatment like psychedelic for eating disorder. And I was surprised by actually a lot of people wanted to have a new treatment for eating disorder because they feel like the current treatment addressed some of the difficulty, but not all. But one thing and so I was surprised by that. That's one thing I learned. I think maybe some of the stigma that is associated with psychedelic can also be quite permeated for our professional field. So that's one thing I learned, that actually patients are keen for something different. And the other thing I learned is, but it's really important how it's being delivered. Being safe is, most of them say that's one of the major things. They wanted to have monitoring that is in a safe, contained environment. But not just safe in a medical sense, but also in a psychological sense. They wanted to be supported throughout, to have supported before and during and afterwards. So I think that's kind of what the field is thinking, is that it's important for us to support the patient during the process, not just to give them the medication like a drugs, but kind of encourage them towards recovery.
And Carol, tell me a little more about your survey. How many people did you survey, and what was the general sense of the most important findings from your survey, beside what you mentioned about safety and structure?
Yeah, so it was 200 people has replied so far. Hopefully more people will complete the survey. It's in the UK. Is to get the view of people who have eating disorder on the view of psychedelic treatment and alternative treatment. So yeah, some of the things I learned. The other thing we also learned is that there will be a subgroup of patients who are not keen on this. So I think it's not like a treatment that will fit everyone, but it's something that can be offered. But I think some other people also mentioned on the panel is that we also need more trial because of the safety. Because people with eating disorders, like especially anorexia, has got cardiovascular disease, the difficulty, and also low BMI. And that's something we need to make sure the drug is safe if we have to give them. So that's another thing that came up in my survey.
Well, Reid, do you have anything you'd like to add in terms of what you've been hearing about the context for effective delivery of this treatment, or the way in which you see your research going?
Sure. Yeah, I can give a brief overview of some of the research projects we're involved in currently. And we mentioned the MAPS MDMA study for anorexia and binge eating disorder. Adele and I are working with MAPS on that one. And she, as she mentioned, it's a safety and feasibility study, which is exciting because it draws from what's been learned in other studies to date, but will help inform the safe and appropriate use of this medicine in particular. That's one that's coming up this year that we're excited about, a multi-site study. Adele, as she put in the chat, has published on ayahuasca and eating disorders, and we're doing some follow-up research to that where we interviewed ceremonial leaders working in the with ayahuasca as a plant medicine on how this medicine might work for eating disorders and what are some of the safety considerations and ways to use it properly for the best possible outcomes. I completed a group-based ketamine study for eating disorders at Center for Change here in Utah last year, and we're working on writing that up for publication. And Adele and I are beginning this month a preliminary clinical trial to validate a psychotherapy model that we've called emotion-focused ketamine-assisted psychotherapy, studying in both depression and anorexia nervosa. And then we're planning a multi-site study of emotion-focused ketamine-assisted psychotherapy. We're calling it FCAP, and have been talking about this collaboration with Carol and Janet and many other sites. And I believe Janet's involved in a very interesting psilocybin study out there in the UK. Maybe she can touch on that.
Well, it's one of these studies that has been planned for a while, but is taking a long time to get going, to get access to the drugs and the funding for it. So that hasn't yet moved forward, but on the other hand, it's done with Professor David Nutt, who, if those interested in the area, he is quite a leader and has got great experience of it. They've just finished a study on alcohol in psilocybin with he presented the results that they're not yet published, but that seems to be good effect. And similarly, there's also a study of ketamine with psychotherapy for alcohol showing good effects. So I think there's sort of accumulating evidence coming, but these studies are very hard to get going. Interestingly, the one on alcohol and ketamine did have MRC funding, our Medical Research Council, and that's unusual.
Adele, can you pick up on this thread to the extent of, I would find it valuable, perhaps I hope our listeners will too. Could you give, without any names or revealing details, an example of a patient for whom this was very helpful? And we've also had questions that perhaps you can work in. What issues in particular do you think the psychedelic therapy addressed that don't tend to be covered or covered well in cognitive behavior therapy or interpersonal therapy, perhaps even in emotion-focused therapy?
Of course, yeah. Well, I'd be reluctant to critique the therapies that are out there because I really do believe that we are better together and we have to draw on each other's strengths to find the right formula for each individual person. But I can speak to some anecdotal evidence that I've been privy to, but also some of the interviews that we conducted where some participants talked about if we talked about classic psychedelics, talked about how there was a focus on embodied knowing. So in terms of like self-love, they could tell themselves, you are worthy, you are beautiful as you are inside and out, but somehow they were able to move that knowing from their minds into their body, into their heart, for example. So that was one of the features that they talked about. The other is that in their experience under the effect, it created a framework within them that felt safe enough to tap into experiences or memories or emotions that were previously intolerable in another context. And so that the medicine helped to hold them in the context of the holding in the therapy so that they could do that deep dive inside. Another aspect that came up that I think is worthy of mention is the spirituality. And a number of people talked about how either they didn't have a connection to spirituality, or that wasn't a topic that was often discussed in conventional treatment programs, for example, and that some of these experiences allowed them to connect with spirituality in a way that propelled them forward, and actually conducted some population-based research that's under review at this time, where we looked at psychedelic users in the community and we tried to understand how psychedelic use could lead to improved outcomes in a general population. And what we found was that psychedelic users were more likely to endorse higher levels of spirituality, and that increase led to an increase in capacities for emotion processing and regulation, and that increase led to decrease symptoms of mood problems, anxiety issues, and even eating problems. So there's this idea that it can be potentially a more holistic approach to healing. And in my training with MAPS, they talk a lot about the inner healing intelligence. And I'm really grateful to my mentors, who really helped me to understand the power of that concept, the inner healer. And so it really does have this capacity to bypass some of the blocks internally to health and wellness that are fear-based, to access that inner healer, that part of you that no matter where you are in time or space, there's this desire, there's this willingness to heal and grow and prosper. And so those were some of the kind of highlights, I would say, in terms of these processes.
Do any of our panelists have anything to add to that based on their clinical work?
Well, one thing that strikes me, there was a wonderful patient journey written for the BMJ about anorexia. And it was in fact, she was a psychiatrist, but she'd had anorexia when she was 13. And she said, if I've been asked to describe anorexia, I can do it in one word: isolation. So I think that this inability to sort of connect and feel compassion from others and feel a social being is part of that, and this connection with spirituality would be part of that, I would say. Adele, I don't know what you'd say, but I do think that's a very interesting thought about it.
Reid, what are your thoughts on this, having worked with patients?
Yeah, I would second what Janet just said, and Adele. I can remember one example of an individual with anorexia who we gave ketamine to in this group-based ketamine study last year, who had complete disconnection from herself, her body, her emotions, even her tastes and preferences. And it was striking to me after the first dose of ketamine. There was a freedom, a creativity, a reconnection with oneself that emerged from that. And then in the days that followed, there was hunger, there was enhanced taste, there was an embodiment that wasn't there previously. The interesting thing, though, is that this didn't last. It was present for a number of days, gave us a window of opportunity to do the work, a window of neuroplasticity, like we might call it, that does come from many of these psychedelic medicines. But then the real work is the integration in between. The preparation beforehand, but then making those changes last and stick is, I believe, where most of the work lies in the psychedelic therapy process.
Thanks. Carol, do you have anything you'd like to add to that?
No, I think like Adele and Jenna have said like really beautifully what it can do, psychedelic. I think one thing I do notice patients say is that it gives them, allow them to have a glimpse of what can lies ahead, so give them the motivation to get better. And I think that's something that's really valuable, something that's really hard to like provide for a patient.
Let me make a comment, and you'll all hear it, I hope, as a question, particularly a question for Adele. Adele, many of the people who I know who have suffered from an eating disorder or are currently in the often difficult process of recovery, as Janet described it, talk about their disease or their disorder in terms of being tyrannized by an inner object, manifest as an inner voice. They often, as you all know, refer to that inner object that they're both tyrannized by and dependent on as Ed. Ed is a schema that consists of a list of rules, a list of shoulds and musts and oughts, and something that the patients feel they're reliant on to keep themselves from falling apart. That this voice, which appears to other people to be irrational and destructive, is for them often, at least in part, a source of salvation. This is what I need to do and be in order to stay in control and to stay as a presence in the world. Otherwise, I'm going to be lost. And loss could be portrayed as being fat or out of control or whatever the set is. What happens to that voice? One might think that if you relinquished control, or involuntarily even, as LSD or psilocybin or ayahuasca was beginning to have its effects in the brain, that voice would become louder and larger, like some nightmare from Fantasia. And it would all be impossible to control and out of control. And yet what I'm hearing from all of you is that's the very opposite of what seems to happen when this is done correctly with the correct person. And I'm wondering, am I missing something? I'm not a clinician, but I have talked with and read a lot about this. And that's what I hear over and over and over again from males, females, younger, older. I'm interested in all of you, your response to that.
There's so much wisdom in what you're saying, Michael. In fact, that wisdom really needs to inform how we approach the work, because from my experience, my research, my clinical practice, when you try to, get rid of the eating disorder, that stance can actually make it stronger. And what I've learned, again, through my mentors in this space, but also through the research and discussion with people who have had these experiences, is that it's a different framework. We want to get to know the eating disorder, and we want to use these opportunities to actually hear from the eating disorder in a different way. Like, how are you trying to serve me? How have you helped me in the past? So that you can actually change the relationship with that inner critic, with that inner driver, because fundamentally it has quote unquote good intentions. And if we can work in that space to change the relationship between the self, the self who's present and working towards recovery, and the self who really is connected to the eating disorder for protection, for safety, etc., then that's, we talk about integration post psychedelic experience, but actually that integration can happen in the actual context of the experience, where it's like, oh, these pieces are coming together to work together in a different way. So that's one way that psychedelics can help the softening, the integration of that critic into the healthier part of the self, so to speak. The other way, and Reid alluded to it earlier, some psychedelics give you a break from your default mode. And so when you have that break, you have the opportunity to see connections that you didn't see before. You have the opportunity to make connections, both insight-wise, but also at the brain level, so that you can become more resourced and have greater insight, more awareness in terms of what's going on and the decisions that are in front of you, and the people who are around you who can be helpful to you, perhaps, so it's this opportunity to get a glimpse of self, of others, of the world, our place in it, without the heaviness of that eating disorder voice that is all too common in individuals who are suffering.
Reid, your thoughts on this?
Yeah, so it's interesting because just a few thoughts to add to what we started with about how and why psychedelics show some promise and potential for eating disorders. Psychedelics are special medicines in my opinion. The way they show us what's in our blind spots, we like to call it shadow work. And then as Adele mentioned, there's this connection with something greater than yourself, the realization that you're not your thoughts, you're not your inner critic, you're not that voice. There's much more to that. You start to see and feel and embody more of that self-worth. The ego is deconstructed, examined, and we get a chance to reconstruct it. We've built up so many walls by the time we're adults. We start to close off to so much of our lives, and have this, we can end up with a distorted view of who we are and what we're capable of. And I do think that psychedelics accelerate the process of the transformation and the healing of this kind of issue. Conflicts rooted in lack of self-acceptance, for example, are cut off at the source. Neurotic behavior patterns can melt away. Pain and suffering can be transformed into this path of becoming utterly alive and freer access to your real self, even the divine within, if you will. So yeah, I'm just so amazed at what these medicines can do to help the therapeutic process along when we otherwise might feel stuck. So.
Janet, how about you?
Well, just a thought on that, because we know that there is a potential always for recovery from these disorders, and that when we see people who have recovered, they often have such post-traumatic growth, this is naturally, but it takes so long, and they contribute so much to society, because the traits that put them vulnerable to getting an eating disorder make them wonderful citizens. And so these medicines can perhaps just put a little bit acceleration on that process, because the problem is that the symptoms, the starvation, increases stress, reduces brain plasticity. So people get into such a stuck pattern. And so being able to have a window to change these things is very helpful, I think.
Carol, do you have anything you'd like to add to that?
Nope, not specifically. I was thinking more of like not just the medication itself, but also the kind of work that Adele has been alluding to about the therapy aspect, I think.
We've had several questions posed to us in the chat room that revolve around the issue of trauma, which we know that not all eating disorders are accompanied by post-traumatic stress disorder or post-traumatic symptoms, but we know a fair number of them are, and when that is the case, there are often added challenges. That is, challenges added to the coexistence of an eating disorder, depression, anxiety, perhaps substance use or abuse, and then you throw into that mix post-traumatic stress disorder. Might psychedelic-assisted psychotherapy be particularly helpful in that instance? Or might you stand back and say, wait a second, before I try this, we need to work through a lot more?
I can speak to that. Michael Mithofer and Timothy Brewerton and I have just completed a manuscript talking about the potential of MDMA for individuals who have an eating disorder and also PTSD. And the work of MAPS and others have really paved the way in terms of demonstrating the potential for MDMA in particular. And there are other substances too, but this is just happening in real time. And there's a lot of overlap. And Michael Mithoefer shared a case study in this paper of an individual who not only was suffering with PTSD, but also pretty serious disordered eating. And they really illustrated in such a beautiful way how the two could work together well. I do think that we have to be cognizant, though, of the potential for additional medical risks when we're talking about eating disorders, especially related to cardiac issues, low weight in general. We don't know enough about that yet, and so we hope that our research will help answer some of those questions. But it did come up at least a few times in the context of the MDMA and PTSD study that we know about. And so I think that there is great potential. And also, again, the wisdom of your question, like, do we need to be more careful about these things? Yes, I really do think we need to be more careful about these things. And I think that individuals with eating disorders in general can be viewed as a vulnerable population. And I think that as researchers, as clinicians, we have a responsibility to create, to inform our research in that way, so that in our practice, so that we can create a container that is safe, not just for the individual who's suffering, but their families too. And again, I mentioned it earlier, but eating disorders, I feel, and in huge part, thanks to Janet's work and her team, have really kind of shown us that a systemic view of treatment is important, because eating disorders affect everyone. Everyone deserves health and healing, and also carers, caregivers, when provided with specific skills or education, can really bring so much power to the treatment in a really good way.
Janet, your thoughts on this?
I was so busy absorbing what Adele was saying. I wasn't thinking of my next statement.
I'm curious about your thoughts on if you can address it from the standpoint of risks or standpoint of possibilities.
Yeah.
But I think many people who know someone who has post-traumatic stress disorder or have it themselves would wonder. There are trust issues, there are over-arousal issues, there are all kinds of issues in working with PTSD.
Yeah.
Is that particular problem or particular risk in this kind of work, or is this kind of work particularly well suited for people who have, as Carol said, comorbidities, including post-traumatic stress disorder?
What we do know is that people who've had trauma in childhood don't respond and are depressed or have other problems, don't respond to medications, antidepressants in the same way, but they do respond to these different forms of medications. So I think there is potential there because of the different biology that's around. So, but I do agree that we do have different sorts of anorexia nervosa. Some people have a more autistic spectrum, more obsessive compulsive. Others have more of anxiety and post-trauma type of profile. And we're going to have to see what matches what. At the moment, we're not totally sure how to match our treatment to these different perspectives. But on the other hand, compared to so many other disorders. Our disorders are quite clearly defined, but we do need to think about these things. And similarly with binge eating disorder, we know a proportion will have ADHD. So there are often these developmental issues that we have to think about.
Carol, do you have anything you'd like to add to that?
Yeah, I think it's like also the experience can be different each time we give someone, like for example ketamine, and like it's not guaranteed. But I think in order to build trust, people get to know the team that is providing the medication, and also the dosing can help to build the trust between them, because you can start quite low dose so they feel quite safe before we can't proceed. So I think there are things we can do and work with the patient collaboratively, decide what's the best treatment plan for them.
Yeah. Reid? As a psychiatrist and medical officer, what are your thoughts about working with patients who have some significant form of trauma in their past and currently have post-traumatic symptoms?
Yeah, a few thoughts on that. And in general, I'd just like to emphasize what's been pointed out, that psychedelics are not for everyone. There should be a careful screening and preparation process. And for some people, there can be even dangerous medication interactions. I think many people have probably heard about the potential drug interactions with the use of ayahuasca, but in eating disorders in particular, with psychedelic medicines, I think there needs to be an even more careful screening and medical evaluation process. With regard to trauma in particular, I do see the same kind of thing where there's a chance of stirring things up or feeling worse before feeling better. And there needs to be that safe container, that support by the treatment team, by family members, caregivers along the way. And just to follow up on the MDMA comments, there was some recent data shared by MAPS within the last month or so. That's just so exciting with the potential of MDMA for PTSD. And it is just kind of blowing away treatment as usual in terms of response rate for PTSD. So I see MDMA-assisted psychotherapy as a very exciting tool that's coming down the pipeline for treating trauma. And we like to think of it as just like not every medicine is for everyone, there may be a combination approach, and more study, more algorithms are needed for this. But ideally, in a perfect world and in the future when these things are available, I could see giving MDMA with psychotherapy to someone for healing from trauma, and then following on with, say, a medicine like psilocybin for a particular eating disorder. And in general, the psychedelic medicines, I like the potential that they have to get more at the source of the problem. It's not why the behavior, but what is underneath the hood, why the pain, why the suffering, why did the behavior turn to this? So I think that's it from my end on that topic.
Right. I have a question that I'm going to take advantage of since I'm moderating. My own experience with psilocybin suggests that it's not without its effects on the gastrointestinal system. I remember very profound stomach cramps and some vomiting and so on. After I got through that, the experience I found to be revealing, transformative, incredible in some ways. And I've read, at least I believe I've read, that ayahuasca is also not that easy to get down and keep down right away. Are these kinds of things issues in particular with working with eating disorder patients? That is the plant-based psychedelics.
Yeah, so we actually asked those questions when we surveyed individuals with eating disorders who participated in ceremonial ayahuasca drinking. And we asked them specifically, how does the purging compare to eating disorder related purging? And it was unanimous. Every single person interviewed, and granted there's a selection bias, but every person interviewed talked about how different of an experience it was, where purging in the context of an eating disorder symptom was experienced one way, like a desperate attempt for relief, for example. The purging in the context of the ceremonial ayahuasca drinking was more related to letting go of pain that fuels the urge to purge in that eating disordered way. But you will hear people talk about the foul taste of ayahuasca, and that's a true statement. And purging of different kinds is something that can happen for people. It doesn't happen for everyone. In fact, one woman shared that she didn't purge at all. And the message that she received was that she'd done enough purging in her life, that she didn't have to purge in that context, in that setting. And so that was kind of it was a beautiful experience, not purging. But yeah, there are definitely challenges that we need to examine, particularly with this population. The other challenge I would note would be the preparation process in terms of the lifestyle modifications. With some, excuse me, with some of these substances, you have to change your diet for a period of time. And so with people who are already feeling stressed about food rules and et cetera, that can pose a problem. And so we also did ask them that question. And some people did say that, yeah, the preparatory diet activated some thoughts that in a way that was more intense that they'd had before, and then it scared them a little bit. So it's a very good question, and it's one that we as clinicians need to be mindful of, so that when we are preparing for people, we're kind of letting them know these are the possible experiences you may have leading up, during, afterwards, including that potential dip. And these are ways that we can support you to manage those potential challenges.
So this goes back to what all of you have said about the importance of thinking of this as the psychedelic aspect as being assisted by therapists who prepare you for it, who are there with you, and who are there afterwards to help you work through the benefits and perhaps some of the challenges, and to, as Reid said, to make this an integrative experience and not a fragmenting experience.
And to take that point further, I think it's really, really important, and we've talked about it a few times, but to consider bringing into the fold the loved ones of the person who's struggling, because you can have a psychedelic experience and it can really transform you in a big way, but then you go back home and your family members don't understand or don't know, or it shakes up the system a little bit. And so what we're really trying to do is advocate for family-based psychedelic medicine in various forms, whether it's providing education and support to family members so that they can provide a more recovery-focused environment for their loved one, or bringing in the family member to participate in dyadic work, or in perhaps more extreme cases, what we've heard of is that in situations where the individual with the eating disorder is too medically compromised or psychologically fragile to engage themselves in this kind of work, that their caregiver, their spouse, or their parent could actually participate in that therapy on their behalf, asking, how can I help my loved one in this way? So we're far from getting to that place, although in one of our studies, we do have systematic caregiver involvement where we're teaching them skills, giving them education so that we can create that more supportive environment. But I really think we need to start thinking about this now, how we can continue the legacy that eating disorders has really kind of brought in terms of family-based work to bring healing to the system.
We've had several questions, and I'm going to start with Janet and perhaps move to Reid on this. We've had several questions about the neurobiology of eating disorders and the relationship between what's known about the neurobiology of some of these psychedelic drugs. Janet, could you talk about why, as far as we know, psychedelic drugs might have a positive effect on issues such as attachment, or issues such as panic, or issues having to do with repetitive or obsessive behavior, why we might expect these medications to have a positive effect if we look at them from a neurobiological perspective?
Well, one way in which these medicines are thought to help is that they might help neuroplasticity and reduce some of the stress-related factors, such as inflammatory markers, etc. And they do work on different transporter systems. So psilocybin works on 5-HT, but it does work in other ways as well. And glutamate GABA systems and brain neurotrophins are implicated in ketamine. So we do understand these pathways quite a bit, and we do understand that with a chronic severe mental disorder, isolation, which is a trauma in itself, the stress system being activated, and of course with the anorexia we have problems with nutrition. So the whole body stress response is highly active, and these medications seem to be able to ameliorate some of these aspects and allow perhaps neuron growth and new pathways, sort of these new slopes down the ski slide as Reid's metaphor says.
Reid?
Sure, yeah. I like to look at, and I completely agree with everything Janet said, and to add to that, I think looking at how psychedelics work compared to traditional psychotropic medications like an SSRI as an antidepressant or anti-anxiety medicine, I think is interesting, because SSRIs, they work on the serotonergic system, but the result is some reduced responsiveness in the limbic structures of the brain and some emotional blunting. But psychedelics target a different serotonergic receptor. Like, for example, the 5-HT2A receptor is a big one that's often talked about as a target of classic psychedelics. And this leads to this flood of serotonin release, and the other effects from targeting that system result in enhanced sensitivity, emotional release. And when you combine that with psychological support, that becomes a very therapeutically powerful strategy, because the serotonin system is expressed all over the brain, especially in areas of cognition, emotion. And so what happens with regard to eating disorders, as an example, this initial blast of serotonin, you get this short-term psychedelic experience or psychomimetic effects, or the trip, so to speak. But then the longer term, especially with that therapy, you get a loosening of the mind, an overall increase in optimism for most people, an openness to the therapy and recovery process, and enhanced well-being. So that's another way I see them working neurobiologically.
We've had several questions picking up on that, Reid. We've had several questions from people talking about the neurobiology of attachment and the impact of psychedelic-assisted therapy on, there's no specific set of neurons that are related directly to and only to attachment, but that those systems that are involved in attachment, are they affected by psychedelic-assisted therapy? And if so, do you see at least some preliminary changes afterwards in patient-therapist relationship or family relationships or things of that sort?
Maybe I can speak to that with regard to MDMA-assisted psychotherapy, because it is a very powerful example of, I think, what these questions are asking. So the therapeutic mechanism of MDMA centers around, well, I like to look at three broad categories: trust, fear reduction, and emotional engagement. And so the MDMA increases oxytocin levels, strengthening the bonds of trust between therapist and client and caregivers, family members, for example. It also increases this this prefrontal activity and reduces amygdala activity, resulting in fear reduction, and lets you go towards your emotion instead of shying away from them. And then its stimulant properties, with more of its effects on norepinephrine, and then what MDMA does with serotonin can also enhance the extinction of these learned fear responses that does result in a neurobiologic mechanism of healing those wounds from trauma in the context of a therapeutic relationship with client, therapist, and ideally with the family and or community support along with it. But I'd be curious if other panel members have anything to add to that in terms of the question Michael asked.
No, I think it's a really interesting point, and we know that family treatment can increase oxytocin, don't we? And we know that oxytocin reduces stress and arousal. I mean, we've shown that giving it intranasally, it reduces the cortisol quite quickly. So, but we need to investigate this more, and yeah, there's so much we need to do. But I think that would be an interesting mechanism, and people are right to be saying this is what we're interested in, is this attachment relationship. So that's why having the family support is so important.
We've reached the point in the program where we need to start finishing up. First of all, I want to say thanks to all the people who are participating and have sent in a wealth of really good questions and comments and suggestions. I'm sorry we can't get to all of them. I'd like to ask each panelist to take no more than a minute and a half and to talk about anything they feel they want to re-emphasize or that they haven't yet had a chance to talk about, or any closing thoughts. So let's start with Carol, and we'll just move across from Carol to Janet to Elle. Carol?
I thought it's amazing how many people turn out for the webinar, and how interested people are, informative about the using psychedelic for people with eating disorder. There's so much to learn about it, and there's so much we need to find out. And I think this webinar really make us think about some of the questions that we can try to address in the future, designing the right trial and study to do that. But it's just been really informative for me too.
Janet?
Yeah, well, I like Carol, I think it's been great that we've had participation from people with eating disorders, or people who care for people with eating disorders, and this integrated approach is what we're asking. And so I think if we can work together, but we do have to, overcome these hurdles of evidence-based, that sort of thing, and so we need everybody's help, and we know how wonderful people are being in this time of COVID, helping with trials. So we hope that we can do this in this field that sorely needs new treatments.
Adele?
Yeah, I would just add to what's already been said that I think as a field we need to commit not just to the exploration of the potential of these medicines, but also related to the risks, to have a very balanced approach. And I guess I would just reiterate that we are all very interested in promoting research in this field in a good way. And if people feel called to donate, psychedelicinstitute.org is a not-for-profit organization, and there are opportunities there. You can also subscribe to our mailing list, where we can share with you updates about different research studies and opportunities. And really want to thank everyone on the panel who joined together for this, and to thank you, Michael, for being such a wonderful moderator, and of course everyone who participated. It really does help us to clarify the best path forward.
Reed?
Yeah, I would echo what's been said and just thank everyone for these thought-provoking questions. I want to save them and dive into them deeper, and would love to keep this conversation going. I think it's just such an exciting time for mental health. It's a new era we're entering into with new innovative options. We also need to navigate it carefully, learning from history, collaborating closely across disciplines and with all those involved, from patients to family members to providers alike. But overall, it's so exciting to see that psychedelic medicines are finally being brought to the people who really need them. And my hope and prayer is we can open up more access to these tools in a very safe, prudent, evidence-based way to alleviate suffering and help people grow into the best possible version of themselves.
And I would just add, Michael, that I think it's also really important to acknowledge the Indigenous communities, in particular when we're talking about the substances that have that history, because we really do have to be extra careful and invite everyone to the table so that we can figure out a way to translate these medicines into our healthcare system in a way that is very respectful, and thinking about the various issues that come from doing so.
Yes, Adele, it does sound like, if I'm not reading too much into what you're saying, that many of these drugs have a long history within a ceremonial context. Mm-hmm. And we would be foolish as a field, and I don't use that word lightly, foolish with a capital F, to ignore the fact that as psychotherapists, even as clinical scientists, we are constructing a different type of ceremony. Mm-hmm. And thus we need to learn from people who have a long, long history with effective ceremonies.
Absolutely. We're curating an expert panel, and we're not going to define who the experts are because we're visitors into this space, when it comes to some of those plant medicines. And so I completely agree with your use of the word. I think we really need to be very thoughtful and deliberate. Mm-hmm.
I'm going to turn it back to Deborah now. Deborah, could you make sure to inform people, if you aren't already planning to, whether or not a copy of this webinar is available to people who came in late or weren't able to be present as we've been talking?
Yeah, we've noticed in the chat, people have asked, yes, there will be recordings available over the next couple of days. Give us a couple of days to get it up on the website and you'll all receive that. I want to echo what Adele said, and I'm glad that she brought it up about respecting the culture of where this all came from. And I want to just give a really big, sincere thank you to all of our panelists, Reed, Carol, Adele, Janet, and our amazing moderator, Michael, for sharing their knowledge with us. I've never seen people so active and asking so many questions, which means that there was just endless value to this discussion. So I thank you all very, very much from me and from PsyTech. On that note, I would also like to share with everybody our next webinar, also with you lovely folks, so that you know what's coming up. It's a very interesting panel on mystical experience, religion, and psychedelics. It has hosting a Rabbi Zach Kamenetz and Pastor James Lindbergh, who are part of the Johns Hopkins trial a few years ago, with also Chief Investigator William Richards, who will be discussing self-awareness and mystical experience, with moderator Iris Selkirk, who is a good friend of PsyTech. So please register for that as well. And again, thank you so much, everybody, for your participation, panelists and attendees and moderator. Have a great day, everybody.